I see we still have very few attendees, but I think we may need to agree that maybe at some point we start and the rest of us join, especially because we also want to be respectful of people's time. And we are hopeful that people will keep joining us as we go along. And for those who are joining us, thank you very much for joining the monthly Kenya Psychiatric Association monthly meetings. And the hope is that at least once a month, we can be able to meet and discuss matters of interest to our practice. And it's also important that we also do this, as we do this, we also make sure that members are getting the CPD points that they need. I know all of us at the end of the year try to look for CPD points, but from the CPD desk, the hope is that we can keep doing these meetings so that we make sure that at the end of the year, no one is asking for points, that everyone will have got enough points. And I hope you're getting points as you go along. Also, please feel free to join the other meetings that we keep sharing. I know other than the monthly KPA meetings, we are also having meetings through Kenya Medical Association, the Tuesday webinars. And those are also opportunities for us to discuss mental health, of course, in the context of interacting with other healthcare workers, but still an opportunity to get CPD points. So this year, we are hopeful that at the end of the year, no one will be in need. So don't quit joining us, but also more importantly, to keep sharing knowledge so that at the end of the day, we can improve our practice as a group. So it's now 6 minutes past 7. I know we are few, but we won't get discouraged because we are not panelists alone. At least we have some participants. So I think I'll allow myself to start this meeting so that we don't take longer time. And today we thought it wise to discuss the challenges of managing personality disorders. We know that many of us would have interacted with personality disorders in our patient care, and sometimes these patients don't present as personality disorder. They'll come with substance use, they'll come with all the other things, and we all likely have had experiences of having difficulties to manage the patients, or patient is not improving, and we are hoping that our presenter today is going to help us unpackage these challenges and take us through some reflections. And at the end of it, hopefully we can, if you have a point, you can raise your hand and we will allow that you are converted to a panelist, so that at the end of the day, you can contribute to this discussion. So our presenter today is Dr. Linda Nyamute. Dr. Linda Nyamute is a young psychiatrist. She graduated recently, well, not too recent, I think it's 2-3 years, not yet old enough to be called an old psychiatrist. And also a very young lady who is very passionate about many things, including social media, and she has brought a lot of energy to the mental health field through her social media passion. And as you may know, like May Mental Health Awareness Month, she's the one who's been leading us, and we truly appreciate Linda for that. She's also a member of the National Executive Committee, and she currently works in Kisumu County. I know before then she worked in a very interesting county in the arid and semi-arid areas. That must have been in Isiolo, and maybe she should tell us how it went out there. So thank you very much, Linda. Karibu. Please take us through the challenges of managing personality disorders. Karibu sana.
Thank you, Dr. Yes, working in ASAL, called ASAL, arid and semi-arid lands. Yeah, it has its good side and its bad side. Cultural exposure, I think that was the biggest take home. Having grown up, born, bred, grown up in Nairobi. Yes, anyway, that aside, I think we may have to have a different platform to discuss that. Allow me to share my screen. All right. Yes, personality disorders, talking about the challenges in management. So just to begin, maybe we could do a bit of some operational definition so that we are all on the same page when these terms are put out there. So when you're talking about personality, personality basically refers to the enduring characteristics. So these are characteristics that have been there over and beyond some time. And also the behavior that now will comprise a person's unique adjustment to life. How do they respond to different and unique situations? Who are they basically? What do they like? Their drives, their motivation, their values, their abilities, and basically also their emotional patterns and how they relate to other people. So personality is influenced by a number of factors. I like this biopsychosocial approach to things in psychiatry. Biological things that can influence personality include things like genetic, hereditary, some personality are inherited. We have things to do with physical features. People who are maybe a certain weight, the much leaner or much heavier have a different, have been known to have particular personalities associated with them, height, different height, the different color that we have. Yes, things to do with psychological are attachment style. This we develop when you are much younger, in childhood. Is it secure? Is it insecure? And how that will eventually lead to the kind of personality that you have. The temperament. So that's basically, are you irritable? Are you a relaxed, generally a relaxed person? Are you quiet? Are you social? And such like things. Intelligence also influences, especially things to do with emotional intelligence, social intelligence, that can also influence how well you probably are maybe adaptable or more social or less social. And also this now brings also the aspect of like situational personality, such that you find the character that you'd be in maybe your workplace. You're a doctor, the character you'd be in the workplace is not the same personality that you bring out when you're with your friends. It's not the same personality you bring out when you're with your family, because of that aspect. And the social, of course, the upbringing, the environment you've been brought up in. That includes things to do with violence. Is it an environment that was open for you to be able to freely express yourself, for you to be able to express your needs, or is it one that you want to talk, your mouth has been slapped, and now you start keeping more to yourself? You're not able to sort of express your needs, yourselves, how you're feeling. So is it also an overly nurturing environment? You know, of course, this can also lead to like an over dependency sort of a style. Overly rewarding, such that you've done something small, or here a reward. So now growing up, you feel like people should also praise you. Of course, social circles, the peers in school, peers at home, they usually say, show me your friends and I'll show you who you are. So yes, your social circle also influences. And then also, who are you in that particular social circle? Are you the one who stays back, the one people bully and make fun of, and the one who takes care of everyone else's needs? Are you the one who's always being praised, the gang leader, the one everyone looks up to for advice and all that? Then cultural norms as well. What is normal in the community? One common thing we usually hear is that Kenyans are naturally rude compared to other, maybe our neighboring countries. Whether it's a myth or not, I mean, that's a discussion for another day. But yes, the culture, because for us, we don't find anything unusual with it. So for us, that is normal. Maybe if you go to a different setup, someone else will be like, you know. So also the community you come from, they're said to be very temperamental, very easily angered, if I may use that word. So, but within the community, I mean, that's not anything that's considered outside the norm. Then, of course, now religion and spirituality always do play a very important role in who we become. Sorry. Yes, so that is about personality. So now what makes up your personality will now be the personality traits. So we have these 5 personality traits. Initially, there used to be 4,500 traits or thereabout. It took about 100 years to collapse them to these 5 personality traits. This now, basically as they are, openness. So there's someone who's, so this is the ability for you to be curious, to be original. Are you open to new ideas, creative? Then we have conscientiousness, being organized, systematic. Are you punctual? Are you someone who is able to plan things, or are you just doing things haphazardly? Extroversion, being outgoing, talkative, enjoying social situations. Agreeableness, so that's being tolerant, or are you completely antagonistic? People are talking about this and they're like, no, everything people discuss, their solutions come disagreeing, or rather finding something wrong, problem with every solution. Neuroticism, this is basically to do with the emotional aspects. Are you moody? Are you temperamental? Are you irritable? Are you anxious? All right, so this basically just shows the extremes if in those aspects that we've talked about. So for example, in neuroticism, if it's very high, you can have emotional lability. In extroversion, if it's very low, social withdrawal. For agreeableness, if it's very low, you don't agree with people, you always think you're right. For example, can relate to grandiosity. So those are traits. Now, we all have traits that contribute to our overall personality. So now, when we talk about a personality disorder, this is now a long-standing pattern of instability in mood, including now interpersonal relationships and self-image that is severe enough to cause extreme distress or interfere with social and occupational functioning. This is by the American Psychological Association definition. So as you can see here, it's a continuum. So you have healthy personality functioning, then you can have some problematic traits, the personality traits. So some are off, but yeah, then you can have many problematic traits then before you get to actually having a diagnosable personality disorder. So they usually talk of the 3 Ps when it comes to personality disorders. The first one being problematic. Are the traits problematic in your day-to-day functioning such that it's causing distress either to yourself or to others, and also in your social space? Then persistent. A lot of them start maybe around late adolescence to adulthood. So for us to diagnose a personality disorder, normally we give it about a year, at least 1 year before you can say someone has a personality disorder. So it's something that's persistent. Then it's also pervasive. It should be affecting different areas in your life. So if it's just affecting this person is probably very grandiose, maybe in school only, but not at home, or maybe at work only, not at home. Are there other situations where they are grandiose, or is it just one area? So the disorders, personality disorders, are quite collapsed: cluster A, cluster B, cluster C. This is by both the DSM-5 and the ICD-11 classification that we use in mental health. So cluster A are predominantly the odd thinking and eccentric behavior. Cluster B are predominantly the dramatic and erratic personalities. And then the cluster C usually have severe anxiety and fear. So in those clusters, you can see the personality disorders that fall within that category. So you'd ask, what is the prevalence? A meta-analytic study that was done last 2020 estimated the prevalence of any personality disorder to be 7.8%. This was a pooled prevalence from about 20, not about, from 21 countries. So of course the rates were higher in had 4.3%. This could be attributed probably to a higher prevalence, or maybe poor data collection or identification, leading to probably underdiagnosis. We don't know. All right. So global rates for cluster A, the most prevalent personality disorder was that in cluster C, which was at 5%. And of course, the lowest was 2.8. Again, this varied from different setups. This is quite different from what we normally would see, because I think for the ones we interact with, usually more cluster B patients. However, we don't have much local studies to back what we say. That is probably just an estimation based on who we come into contact with in the practice. Males, usually more than females in this mental health disorder personality, except in histrionic, borderline histrionic, and dependent personality disorder. Right, so when it comes to etiology, again, it's multi-dimensional, the biopsychosocial approach. I think I'm a fan of this model for etiology, risk factors, management of clients. It helps you have a holistic approach. So for the biological aspects, I think we talked about also in what will determine personality. So other than that, you can have with imbalance in neurochemistry, metabolic disorders, physical health can also cause, or rather be a risk factor, predispose you to the personality disorders. Social and environmental factors, things to do with socioeconomic status, social support, the family background that we talked about, violence in the home, whether it's intimate partner violence, whether it's child abuse, very important. Any life events, and death also could also predispose. Again, these are predisposing factors, not necessarily causative factors. Then, of course, the psychological, your general personality, as we talked about, temperament. So if you have more of an anxious temperament, you probably would be more inclining towards the type C disorders, in case you get a personality disorder. And of course, coping and social skills, self-esteem and emotions can also, if you have low self-esteem, and what is also contributing to that, your environment also could be predisposing you to that, bullying and such factors. What you so that that can pinpoint how things or develop a personality disorder. So when we do management, as minimum, we are tested on matter investigation. Clearly, the physical investigations, we don't have like blood tests, disorders, such that if I do a malaria test that I'm dealing with, if it's negative, I know there's no malaria. Positive, I know what I'm dealing with. So we do have psychometric tests, which we'll also allude to a bit later. However, we are quite limited in matters investigations when it comes to personality disorders. So line treatment recommended for personality disorders is usually your psychotherapy. Evidence-based therapy would be the mindfulness behavioral therapy for your borderline personality disorder, cognitive behavioral therapy for histrionic, among others. Then you also need to plan on how to treat comorbidities, because as it is, patient will come because they have developed depression or they have developed an anxiety disorder. Sometimes it's the families that push them, but sometimes it's also because they've developed another mental illness. So they're probably, and then you find they also have a comorbid personality disorder. So you also need to treat the comorbidities. Then substance use, very important to also be treated. You know, substance use is a risk behavior. So personalities that usually have impulsivity, that's basically the cluster B type of personalities, you will have an increased risk of substance use disorders among these clients. A study done in Europe found that about 60% of the patients who had a substance use disorder also had a personality, comorbid personality disorder, predominantly clustered because of the impulsivity and risk-taking behaviors. Then we have risk aversion, also part of your treatment plan. There's cluster B patients tend to be very, rather having self-harming behaviors, suicidal tendencies. How do you avert that risk? For antisocial personality disorder, there's the risk of homicide. How do you protect everyone, basically the patient and the community at large? Then follow-up and prognosis is usually very necessary in any treatment care plan that you have. However, prognosis for a lot of personality disorders has been recorded to be quite poor. So now, what is the rationale for having this discussion? As we mentioned earlier, there's sometimes an overlap in the management of our patients, such that this can pose as a diagnostic challenge. Am I dealing with schizotypal personality? Am I dealing with schizophrenia? And many a times we want to treat what is more obvious or what is more distressing also to the patient, and also what we are familiar and more confident. Yeah, so not confident or familiar in diagnosing personality disorder, highly unlikely will be able to get it. So the diagnostic challenge symptom. Then of course now the overlap can also bring sometimes when you have patients who have treatment resistant illness, patient for bipolar and don't improving. You've been treating this patient for schizophrenia, but they still have these predominant negative symptoms that are not going away. So we've done first line generation, second line generation. I mean, second line treatment, first line treatment. We've also now gotten to a point now we are doing ECT. The patient is not improving. There could be an element of personality disorder that is also being overlooked when it comes to treatment resistant disorder. Substance abuse, as you've mentioned already, alluded to earlier, we have a number of patients who are not leaving the rehab space. you touch them, they're back. So they're constantly within the rehab system, probably because of an undiagnosed personality disorder. So as we've talked about, we have cluster A with the negative symptoms of schizophrenia that can pose as a challenge in diagnosing. When it comes to cluster B, the mood, or rather the affective disorders, usually have an overlapping element. When it comes to cluster C, we have more of the anxious symptomatology and anxiety, sort of the disorders leaning towards anxiety. So this is also important because how will your adherence look like? A patient who bears insight on what their problem is, and as we said, the personality disorders are a bit difficult to diagnose and treat because for the patient, for them, they're good, they're okay. So why am I taking any medication? What is the rationale for me taking this medication? So probably diagnosing and being able to manage, rather have a treatment care plan for our patients can also potentially increase adherence for patients who have been having adherence issues. Then also mitigating, or rather reducing suicidal risk. It has been documented that when the more, having a comorbid mental illness, morbid mental disorders increases one's suicidal risk. So of course now being able to early identify personality disorders in the face of probably depression or anxiety also help reduce the risk and self-harm. So we have into diagnosis, treatment, and variations in capacity. So when it comes to diagnosis, we have previous slide overlap the personality disorders with mental illnesses. So previous slide, borderline personality disorder with bipolar disorder to do with emotional instability, feeling of empty behavior. So these symptoms, they cut across both illnesses. A purely bipolar mood disorder, or are you treating borderline personality disorder and treating it as bipolar mood disorder, or are you treating bipolar mood disorder in the face a borderline personality disorder somewhere in the horizon? Remember we had cluster A, B, and C. So clusters have overlapping symptoms. For example, cluster B, the histrionic and borderline personality disorders both present with shifting emotions, attention-seeking behavior, and need for excess admiration, manipulation, and of course, they're very dramatic. So sometimes you're wondering, am I dealing with a histrionic patient? Or am I dealing with a borderline personality disorder? So that also poses as a challenge when you're trying to make the diagnosis. There has been a push to try and collapse the number of personality disorders because of this overlap again, so that we have clear symptoms, or clear disorders with clear symptoms, so that it reduces the rather the extreme overlap between the clusters. Then of course, diagnosis also poses as a challenge because a patient insight. So this is not a patient who highly unlikely come and tell you have a problem, personality problem. Maybe, but more likely no. So this will probably be because maybe they're having problems at work or having problems with their relationships. And many a time they're attributing the problems to the other people. It's more of an external locus of control rather than an internal locus. They don't see themselves as, I could potentially be the one who is causing these issues, or my behavior could be what is triggering all these problems within my environment. So the patient also comes and tells you, I'm feeling probably depressed, or I'm feeling anxious, and then, or rather they're coming for management of anxiety, and then you come and tell them you have borderline personality disorder, for example. So the insight, and then you're wondering, my problem is not personality disorder, came in for depression, came in for anxiety and feeling anxious. So poor patient insight usually poses also as a challenge when it comes to diagnosis. Another challenge usually when it comes to the standardization of tools for assessing personality disorders, things to like depression. When we talk about depression, there's a clear tool, PHQ-9. It wouldn't take you much time to fill it. Your MDQ for your mood, bipolar disorders, or your anxiety, anxiety inventory, wouldn't take you much time to fill it. It has been used severally within our cultural setup, so a lot of us would be comfortable utilizing those tools. However, when it comes to personality disorders, the tools which are have been set out for use, one by the APA and the other by WHO, is the Structured Clinical Interview for Personality and the International Personality Disorder Examination Interview. Now, both these tools are quite lengthy, and they may take up to 3 hours to administer a tool to come up with a diagnosis for the patient. Now, given our limited resources, how many patients need to be seen, the 3 hours may pose as quite some time for a practitioner to give to one patient. However, those are the options that we have available. The other thing is, how culturally sensitive are they in terms of, I mean, this has been used probably like the structured clinical interview in the American setup. It's also applicable in our setup. Like also diagnose a personality disorder, maybe in a behavior or a trait that is considered normal within our cultural setup. Then we have the qualitative versus quantitative approach. Times we just say patient has borderline personality disorder. Unlike many other mental disorders, for example, depression, usually say the patient has mild depression or moderate to severe depression. And that will also determine what kind of treatment they get, whether it will be therapy by them alone, whether it will be therapy together with medication. And yes, so it helps to bring about what care plan am I going to give my patient. However, when it comes to personality disorders, it's either you have it or you don't. So if I find out that you have it now, okay, what next? Does that change my care plan? Is it a one shoe fits all for mild, moderate to severe, or is everyone who has a personality disorder considered severe mental illness? Then when we talk about treatment and challenges in treatment, so formulating a care plan that is evidence-based, the resources to provide this evidence-based medicine become a challenge, especially in our setup, being a low resource country, can call us that. So do we also have low human resource availability? How many centers do we have? First of all, we have quite a few number of, what I call it, absorbed psychologists within our facilities, especially I'll talk from as a government employee, yes, we have quite a few psychologists compared to what we need. So when you talk about 3 hours to administer a tool, and then probably the patient would need another hour or so for therapy, how many psychologists do we have who are available to offer that kind of therapy or management plan? Then also comes to the human resource skill base and scope of practice. How many know, or how many are trained to diagnose and offer the therapies, also that to screen diagnose the personality disorders? Because as you see, as you saw with the standardized tools, the 3-hour tools, you have to have been trained for you to be able to understand how to utilize that skill, that tool. So our skill, the human resource, fine, it can be present, but how many are available to also offer mindfulness-based therapy? How many are, trained in that and feel confident and comfortable enough to offer? Then also fragmented services, you find they come here, this is where they'll be seeing maybe the psychiatrist, and then on this other end, they have to go and do their follow-up for maybe the substance use disorder, and then come back this side where the psychologist is probably a whole different town altogether. So the lack of integration of services to be a one umbrella sort of stop. Then the third one is the variations in attitudes, beliefs, and capacities, and now this focuses mainly on us. So studies have been done, and this is proven that some psychiatric professionals have tend to have poor attitudes towards people who suffer from personality disorder. This can be attributed to probably the chronicity of the illness, and what available management and available resources do we have to treat? At the end of the day, it becomes, okay, fine, I've diagnosed you with narcissistic personality disorder, and then what? So some would even prefer not to even diagnose it in the first place, because after I've diagnosed you, what's next? Do I have a plan of management for you? Also, personality disorders have low remission rates. One of our biggest, or rather the poorest prognosis of mental disorders is usually the personality disorders, probably also because of the amount of time it would take for you to diagnose. So this personality has become a norm for the person. Then another contributor to the variation in attitudes and beliefs will probably be due to the symptomatology of some of these personality disorders. Some personality types tend to be very manipulative, have very manipulative tendencies. So you'll find the doctor tries to avoid that patient because they push you probably to write for them sick offs. They push for you to give them medication that you know they probably don't need, sleep medication, diazepams, and all that. So because of those manipulative tendencies, you find some professionals who tend to just stay off, not to be involved with them to begin with. Then, of course, splitting. Some personality disorders have the splitting tendencies. So today, or rather, Dr. Nyamute is bad or extremely bad, and there's nothing good about her. And then now, then there's Dr. So-and-so who's, let's say Dr. Kwobah, who's said to be extremely good. And then she does one thing or does not respond to a manipulative tendency or a request for that matter, and they're now being clustered now again as completely bad. So it's completely good or completely bad, and sometimes it can shift to either side. But of course, now this will lead to medical tourism. You find you're treating them, they are here, the next clinic they've gone to a different doctor, the next they have gone to a different place. So this also tends to be a deterrent in handling or managing these patients to begin with, because follow-up tends to be quite difficult. Then there's institutional stigma. A number of times you find like nurses, even us doctors, we don't want to, that patient, and they have already labeled this patient as quote unquote sumbua, that patient who's always nagging, that patient who's always attention seeking, that patient who's always self-harming. So there's that institutional stigma that can also bring about as a challenge to properly managing and helping our clients with personality disorders. Then, of course, variations in attitudes can also be influenced by just individual characteristics, the social cultural inclinations. So there are people who just don't like dealing with people who are probably self-harming. For example, considering the fact that you've noticed this behaviors, or people who are maybe violent to their spouses or violent to their children. And it's predominantly because it's been caused by the personality disorder. So you say, for me, this person has behaviors that I do not agree with because of 1, 2, 3 reason, or so now you decide not to manage or rather associate with that patient. So possible strategies that could be employed. We have, again, the biomedical psychosocial approach. And many times when we are dealing with our patients, as we said, you could be having a patient who's not responding to treatment, a patient who's constantly in and out of hospital, constant relapses over and over, substance use and evading treatment care plans and all that. So it would be important to just have a reflective practice and look at, could we be missing something else? So have we addressed the biological? Is there anything else in the biological that could be a causation in the biological aspect? Let's say you're dealing with depression. Could there be anything else that could be causing those patients to be depressed? Could there be anything else in their psychological aspect that could be causing this patient to be depressed, in their social aspect? So that reflective practice sometimes may help you actually at times uncover a personality disorder in the face of our usual, or rather our common mental disorders. Then, of course, the use of a multidisciplinary management approach. So we need to have psychologists on board. Again, from a county or rather government perspective, we have very few trained psychologists that we work with. So at the end of the day, even if I find my patient has personality disorder, what am I going to do for them? Yeah, so now including my psychologist, who I assume who would have been trained also in knowing how to offer the therapies for our clients. Brings about the question for, it's a debate that we've been having, what our counseling psychologists can do, what our clinical psychologists can do. Are they all the same in terms of, if I have a patient with personality disorder, can I expect the same from either types of therapy services? Also, quantity versus quality approach. I think this will also be inclined towards what is the main problematic area for the patient, and how are they able to function within their space? Is it everything has now completely collapsed? Is it just one area that they're really having an issue with? Is it maybe now only the only issue they're having is probably depression, but their relationships have not been quite shattered? Or is it everything is just haphazard? So this, I think, will also institute the kind of treatment plan that we can put out for the patient. Then the doctor-patient collaboration in treatment plan. I think it's really important just to help with adherence, because I mean, the patient is understanding, why do I have to take this medication? But in addition to that, or rather this treatment, or go for therapy. But in addition to that, my problem was I have an issue at work, or I have an issue with my boss. Has my doctor been able to address my main problem that brought me to hospital? So having that doctor-patient collaboration in treatment increases adherence and can also help promote insight. Then social cultural factors should also be looked into. Again, many times patient comes and they're still irritable, or they're getting violent outbursts. You add carbamazepine, or you add another antipsychotic to calm them down, but have we factored in possibly other social cultural factors that could also be contributing to the crisis, the crisis that happen in personality disorders. So also in the social cultural factors, we also need to remember the families, because many a times, fine, it's the patient, maybe they've been brought by the family, but this family is also enduring quite something in the space that they are in, especially for patients who are impulsive, grandiose, self-centered. They are probably enduring quite some psychological distress. So it's usually a funny saying that many a times for patients with personality disorders, we tend to treat the family more than we are treating the patient, and basically help the family know how best to manage and live with the patient, and maybe prevent crisis as well. So we need to consider social cultural factors. Then training and research. Again, as you said, a keen eye for identification and pointing, knowing, okay, could I be dealing with a personality disorder? That would not come if, you've not been trained in that. It would not even occur to you at all. So increasing training, and of course, research. We don't know how prevalent our society is. Is it the same as what we found in the other countries, Nigeria, South Africa, that the research had been done in? Is it similar, about 4%, or is it more? Is it less? Is it non-existent? So it would be important to note that, so that we also have probably a better approach, such that when I see a patient who's like this, I'll be suspecting this, or I'll check for this, I'll rule out this once that has been researched, and probably some policy has been formulated in line with that. Right. So I don't know if there are any further strategies maybe that would be included, whether this would work in our setup, wouldn't work. Again, goes back to, we do not have much local data to work with, so as to say whether or not this would probably work for us as a society. So I think I am done with my presentation. And in conclusion, probably when we see our patients, or rather what guided, or rather pushed for this conversation, was our patients who are not responding to treatment. They're constantly in the system. They've moved from Dr. A to Dr. B. They're now in the Dr. F, Dr. G, so that's patient hopping and medical tourism of patients. Sometimes, and it will be very unfortunate for you to feel like my colleagues were unable to sort this out. So maybe I'm the hero over here. And you're still managing for the same disorder that was being managed before. So sometimes also the consultative sessions with whoever had seen the patient before would probably be important to also help sometimes in management of diagnosis and management of our clients. Yes, so yes, I think I'm done. I've been done.
Thank you.
Yeah.
Thank you very much, Dr. Nyamute. If you listen carefully from the beginning, you will appreciate that Dr. Nyamute has done a very good job. I think in my short practice of psychiatry, if I think about a patient who stretched my emotions and drove me to the wall, most likely they had personality disorder. Is the emotional dysregulation, is the excess demands, is the tendency to aggressive tendencies, the impulsivity, the non-compliance, and all those things that Nyamute has reminded us about. And I know it's not easy. A friend of mine, who is also a psychiatrist, keeps joking that the place for especially people like people who have antisocial personality disorder is probably somewhere between a mental health facility and a prison. And actually, there is evidence to show for especially people who have antisocial personality disorders, probably short episodes of being imprisoned or incarceration could probably be beneficial to some of them. And then it's tough. And she's also reminded us that there's no clear medication that the FDA has approved, but there's room for some medication to control aggressive behaviors like antipsychotics, the carbamazepine, fluoxetine also has been tried. And also for impulsivity, because some of the patients with a lot of personality disorders tend to be very impulsive. But most importantly, what has been shown to work is some form of psychotherapy with dialectical behavioral therapy, where you teach patients to control their emotions, to correlate distress, and to improve their relationships. Then there's cognitive behavioral therapy, where they are taught how to just take care of their emotions. And sometimes we were actually hoping to get a psychologist to help discuss this. And of course, there's the psychodynamic psychotherapy, where they are helped to think about the unconscious states from past experiences that may have influenced how they are now. So very tough, but a very good discussion. And we have two questions for you, Dr. Nyamute. One, you mentioned that culture and religion are some of the influencers of personality disorder. And maybe from your statistics, have you singled out which culture or religious faith is most likely to contribute to this? Maybe you can share with us. And as she answers, also remember that if you'd like to contribute, you can raise your hand, and we will request that you will be upgraded to a panelist so that you can give your experience. Nyamute?
Yeah, so I said culture and religion, spirituality influence personality. And I think when we started off, we talked about differentiating between personality and personality disorders. So from the statistics, have you singled out which culture, religious faith? Again, we barely have much data in our local setup. So extrapolating studies maybe from a Western country, so there are many other social factors that could be influencing that, based with minority groups and all that. So I wouldn't extrapolate studies from the Western culture and bring them and say now from what they said, random example, that Black people are more prone to getting maybe borderline personality disorder because their culture is very different. Again, from the meta-analytic studies, the study that has been done, this was not among the social demographic characteristics that was looked at. Religion, I don't know. I've not come across that again. Again, probably that could be an area of of study, of an area of research that you could probably explore.
Thank you. And I agree with you. There may not have been very clear studies that have delineated this, but again, if someone has come across one, it's good to share with us, though we know that culture can shape your personality, and some of that personality can tend to disorder. So that is clear, but which specific one, maybe we haven't enough studies, but we'll be glad to hear if there's a study that you came across. I saw a study that tried to relate, to check the relationship between culture and personality disorders from India, especially personality disorder, but it didn't come out clearly whether there's something specific about that culture that would increase the risk of personality disorder. But of course, we know that our experiences shape the personalities that we develop, and some of that can be deviant. The second question is, can a person grow out of a personality disorder? What do you say about theories associating personality disorder with developmental delay?
Okay, can a person grow out of a personality disorder? I don't know what you mean by grow out. However, as we alluded to earlier, personality disorders are one of the most difficult mental health disorders to manage and treat, because of the reasons that we mentioned. Also, personality disorders, of course, because of the poor insight, become, very difficult for you to tell a person that, how you are is wrong. For them, that is who they are. So, of course, become a bit difficult to treat. Disorder, can you grow out of a disorder? I don't know if you can grow out of any mental disorder. Personality disorder is a mental disorder, so I don't know if you can grow out of a mental disorder. However, in medicine, we never say never. Remission rates are low. However, it's not been said that it's impossible. What do you say about theories associating personality disorder with developmental delay? Maybe you can share with us what theories those are. However, developmental delay at what stage exactly? Because our personalities probably finish forming around our late adolescence to early adulthood time. So personality disorders with developmental delay, probably you are unable to achieve targets because of maybe you're extremely grandiose and you think you know it all, so no one can tell you anything. So you're not willing to learn from other people. So of course that would delay your development maybe in your career. Developmental delay maybe in social, maybe relationships, intimate relationships, of course, because maybe if you're also too much attention seeking, it always has to be about you. It's very difficult for you to develop an intimate relationship with another person. So I don't know, that developmental delay is a bit too broad, but yes, it can lead to developmental delay if you look at it in that aspect.
Thank you. And yeah, I agree with you that if you have developmental delays, it can predispose you to some challenges that can also lead to personality disorders, especially like if you have challenges making decisions early because of your developmental delays. What is the probability that you can get dependent on other people making decisions and maybe eventually even develop a dependent personality disorder? So probably cluster C mostly, but probably there's no significant data that has linked that strongly. But again, we said we are open to learning if you have come across a very strong study that associates delays with specific personality disorder. The last question is schizotypal personality disorder similar to schizophrenia?
I think we addressed this in the overlap of the symptoms. So we said cluster A personality disorders usually have quite some overlapping symptoms with negative symptoms of schizophrenia. So schizotypal personality disorder is not the same as schizophrenia. Schizophrenic patients I think part of the diagnosis is that they need to have hallucinations, which I don't think are present in schizotypal personality disorder. So no, it's not the same. However, as we alluded to, there's usually an overlap in symptomatology, which also causes a challenge in making diagnosis and management of the patients.
Thank you. I think we have done all the questions. I haven't seen whether there's a hand that has been lifted. So, because we had hoped if anyone would like to give input in person, I haven't seen a hand lifted, but we want to, I hope you agree with me that it's been a good reflection on personality disorders, reminding ourselves very challenging, but we are called upon to manage those simple patients and even the more complex ones. Actually, if you look at literature, there is one study I was reading about therapists who and psychiatrists, and they say not everyone can actually manage to take care of personality disorder patients for a long time. So it's okay if you find it very difficult to refer to a colleague, although we hope that all of us can improve our skills. And two things. One is to, of course, be very clear about the personality disorders, the fact that they are likely to be endearing, and the fact that there's not much improvement, but still you're called to support these patients, like a malignancy, a cancer that's not going away, but still there and still need to be managed. But the other important aspect is developing emotional resilience, because we all would agree that they drive you to the wall. And do you attack them if they attack you and say you are the least caring person, or when their emotions are totally unregulated? One time they look calm, the next time they are screaming and out of control. And it's not easy. And I know some of us have even lost patients. I know I lost one patient who had personality disorder, and she kept swallowing objects, and eventually she actually passed on, and it was very painful. And she'd swallow the nail. I remember the last time it was the nail, and she'd come and smile and say, I have just swallowed the nails. And then you'll go, and then she had too many laparotomies, and of course that took her off. So it's our business to prevent death and to reduce suffering, even from the results of this personality disorder. So just continuously encouraging ourselves to appraise ourselves of how to manage them. And also importantly, I know psychologists do this very well, getting some form of supervision. I know we don't do that, especially because personality disorders can stretch you. Where do you seek care? How do you manage to rejuvenate so that you can continue taking care of these very difficult patients? So very important that we ensure that we're also having some form of supervision and sharing with a colleague, of course, in the context of confidentiality, so that we are rejuvenated and we get energy to keep going. So thank you very much. I think there's another last comment, that quotient traits of personality, i.e. openness, conscientiousness, extroversion, agreeableness, neuroticism of personality, have been shown to be same in all cultures of the world. Same traits improve over time with age. Thank you very much, Moses, for sharing that. So we want to thank the presenter, Linda Nyamute. You've done a very good job. We also want to thank all the more than 50 participants who joined us this evening for our monthly KPA meeting. Please keep joining us. So there are two meetings and it can get confusing. We have our monthly KPA meeting that's a bit academic, and we have the Tuesday KMA, KPA, and the Kenya Clinical Psychologists Association kind of combined meeting that tries to help all healthcare workers. So please join the one for taking care of yourself. But this one is academic, every month on a Thursday, most evenings. And we're also hoping that regions can also have their own meetings and meet physically when they can. And as we said from the beginning, we want to ensure that at the end of the year, our members from the CPD desk at least have enough points. And also feel free to share with us topics of interest so that we can meet your needs. And also, if you'd like to be a presenter, this is not for specific people, it's for anyone, old and young. If it's a topic you think for learning purposes you'd like us to listen to and you'll be the presenter, please feel free to reach out to me or to any NEC member. So we want to thank you very, very much for keeping us company this evening. Let's meet next month on a Thursday, but don't forget to join the meetings on Tuesdays. Thank you. Have a beautiful evening until we meet again. Thank you, Linda. It's been beautiful.
Thank you, Dr.
Yes, I'm glad that we did this. Let's keep doing it and enjoy your evening.
You too, thank you. Good night.
I hope you felt as good when presenting. Not
Just quite there's too much to be said, but trying to collapse it.
and then you did it well in very short time. I really appreciate. Thank you. Have yourself a lovely evening. Thank you, Levi, also for keeping us company. We hope to get the CPD points out as soon as possible.
All right. You can leave the meeting. There are people who wait for you to end the meeting.
Asante. Bye-bye. Yes, we are going to, the leave meeting is for Peter.
All right. Thank you.
Okay, sir. Thank you. Bye-bye.